So some indications for prone positioning would be arterial oxygen tension divided by a fraction of inspired oxygen of less than 150 millimeters of mercury um, would classify as putting a patient in prone positioning because of the low level of this. And then a patient receiving PEEP of 7.5 or higher can receive prone positioning. And then uh, bilateral infiltrates on a chest x-ray, and then pulmonary artery occlusion pressure of less than 18 millimeters of mercury. This shows pulmonary congestion in the lungs. And then exclusion criteria. So if you have untrained staff, it would be very unsafe for the patient to be involved in this. You want to have a staff that is trained and knows what they're doing when turning a patient into prone position. And then increased abdominal pressure. You wouldn't want to put a patient on their stomach with this. And then abdominal and chest wound, the same thing. And then C-spine precautions. If someone has a cervical fracture, you want to be very careful, and it would probably exclude them from being able to do this. And then hemodynamic instability. You wouldn't want to put someone on their stomach if they're not hemodynamic stable before. And then preterm considerations, you want to do mouth care before, so suction all the fluid from the mouth and secretions from the oropharynx. And then eye care, you want to just maintain eye care and closure using tape to avoid any corneal abrasion. And then pressure area risk needs to be assessed before turning them over, and then check the pupils for reacting to light and see if they're equal. So some techniques: the first thing you want is assemble a trained staff, and then provide padding and support for potential pressure areas such as the face, upper chest, and pelvis, and then turn the patient prone, and then the abdomen should hang between two pillows for optimal support. And then monitor the effectiveness. You want to note the oxygenation status prior to turning the patient so you know their baseline. So if they start to get worse, then you know that the prone position isn't working for them. And then take an ABG before turning them over into prone position so you have a baseline for that as well. And then also you want to calculate their oxygen arterial tension divided by the fraction of inspired oxygen as well. And then if a patient has a saturation that's increased after 1 hour of being in prone position, draw an ABG and then calculate the oxygen index to see if there are any improvements. And then once back in supine position, draw another ABG and calculate the oxygen index. And if the status deteriorates from what it was in the prone position, then place them back in prone position because you know it's working then. So preventing skin breakdown of the head and neck, you can elevate the head of the bed, and this will minimize facial edema. You also want to be aware of the patient's natural posture, as they may have rheumatoid arthritis or fixed kyphosis. And the head should be positioned where the neck is not extended and where the patient's straining their neck. And for passive movements and limb positioning, it is important to maintain soft tissue length and mobility within normal range of movement and normal resting postures. You want to aim to maintain soft tissue so the patient achieves maximal function at discharge. And then patients in the ICU are usually turned every 2 to 4 hours. For upper limbs, both shoulders should be abducted with elbows flexed. And then in full prone position, abduct the hips and flex knees over the pillow. Alright, so this is the basic prone position. Right here you have 3 support pads. I'm using pillows. You have one under the chest area right here, one under the abdomen, and one under the knees supporting that. And you can have their arms extended out this way, or if the physiotherapist wants to move them back this way, you can keep them back this way too, because you don't want to keep their muscles and joints in one place for too long. You want to be able to move them around. So this is the basic one that you'll see. They can put their head on either side. You can move your head this way. Move your head this way. So with the ET tube, you'll have their head facing up to the side, of course, and some alternatives that you can do. Here, I'll put you down here. Let's do this. I'm gonna put her on her right side. You're gonna help me out a little bit. So I might move this one. And this goes up by like your chest and under your chin right here. And you're gonna flex this knee. Like this. So your arm right here is gonna be flexed with this knee. And then I'm gonna support your feet with this. So if you want to prone a patient and keep them on their side, you can still do this way with 3 paddings, and you can do it on the right or left side to keep them prone.